Okay, we're going to go ahead and get started. Our next speaker is Dr. Navin Pinto. He is a professor of pediatrics in the Division of Pediatric Hematology, Oncology, and Bone Marrow Transplant at the University of Colorado School of Medicine. He is also the lead of the solid tumor team at Children's Hospital Colorado. He received his BA in biology, summa cum laude, and MD from St. Louis University. He did his residency and fellowship at the University of Chicago and did his postdoc fellowship there as well. He has also held several positions at Seattle Children's Hospital from 2016 to 23. He is a member of ASCO, COG, and a member of the Biology Committee for the NANT, which is, you just heard, No Approaches to Neuroblastoma Therapy. He has lectured and done presentations for various committees and organizations, including CNCF, over the years. He will be giving us an update on the Children's Oncology Group and where their studies have led us and what the future holds for patients with neuroblastoma. Dr. Navin Pinto.
Thank you all. It's my great pleasure to be here and present on behalf of the Children's Oncology Group Committee to sort of update you on recently closed studies as well as studies in progress, and hopefully we'll have some time to also talk about future goals for the committee. I have no conflicts of interest to declare. I forgot to include that as a slide. But I wanted to just give a very quick primer on clinical trial phases. This sort of gets rattled off in the clinic, and just wanted to give the audience some background on what the different phases are. And so, you know, drug development really starts mostly in the laboratory, and preclinical development is where drugs of interest may be tested in mice or against neuroblastoma cell lines derived from patients. And if we have some signal that that drug may be helpful, oftentimes our first step is to bring it into a phase 1 trial. So those are first in human or first in neuroblastoma studies where we're really testing a new drug. And one of the things that I like to point out is that phase 1 trials, like those that Dr. Marcellian just described in the NANT, are often determining the safety of a given treatment. Obviously, we want the drugs to work, and we want the drugs to give us better options for neuroblastoma, but really the first step is to prove that those drugs are safe to give to kids. And so that's sort of an FDA mandate for the first phase of a trial. Now, if you have some safety data and hopefully some preliminary efficacy data, this may be as little as, you know, we treated 10 patients and one of them had a nice response. That might be enough data to go into a phase 2 trial where you're treating more patients to get a sort of preliminary assessment of how effective is the drug. And once a phase 2 study is complete, sort of the gold standard is to conduct a phase 3 study. And for most neuroblastoma studies that have been done historically, those are randomized clinical trials where our current standard of care is placed up against a promising drug from a phase 2 study, oftentimes by layering it on top of the standard of care. So if your standard of care is X, it's usually X plus experimental drug Y. That phase 3 data, if patients that get the experimental drug do better, survive longer than the patients on the standard arm, that's usually enough information for the FDA to approve the drug. You sometimes hear about phase 4 studies, but those are largely not necessary in pediatrics. At the top of the graph, you can see that the time frame from the lab to the clinic can be anywhere from 5 to 15 years. I would even say anywhere from 5 to 30 years. And that speaks to the rarity of neuroblastoma. We're in, I think, a better era to speed this along, but this still takes a disturbingly long time, mostly due to the rarity of neuroblastoma. So why are clinical trials important in neuroblastoma? We know, and you guys have probably all heard this, the sort of, I feel like rare is a new four-letter word, but neuroblastoma is rare. And high-risk neuroblastoma is sort of a rare subset of an already rare disease. And so doing studies at a single hospital for a very rare disease can be slow. There are some centers like Memorial Sloan Kettering and St. Jude that see enough patients that they can sometimes do studies on their own. But largely, many centers might see anywhere from 1 to 5 high-risk neuroblastoma patients in a year. And so for that type of a center to do a study on a drug that they're interested in would take forever. And so the many hospitals in the United States and North America have banded together to do trials together to hopefully improve outcomes. And so these collaborative efforts have led to improvements in outcome, as you can see here, that sort of by era, survival outcomes are improving, and this is largely through these collaborative efforts. So what is the Children's Oncology Group? This may not need explaining to this audience, but it is a network of children's hospitals in North America, Australia, and New Zealand. These are the United States sites. I think this represents 191 hospitals, and I think overall in the Children's Oncology Group, there's over 200 hospitals that band together to run these clinical trials. And again, that gets us the numbers we need to make meaningful conclusions about whether new treatments are active. All right, so I'll start with the studies that have recently closed, and luckily there are some recently closed studies, and then we'll talk about the active studies. So from past experience, I know that not a lot of families with non-high-risk neuroblastoma come to CNCF, but in case there are any families here that are listening that have a child with non-high-risk neuroblastoma, we just recently closed a study, AMBL 1232, which I think I wanted to highlight, even though most families are interested in high-risk studies, because it's what I hope the future will hold for high-risk neuroblastoma is that we're using our knowledge of the disease to sort of draw back. So we know that outcomes for kids with high-risk, non-high-risk neuroblastoma are quite good, and so we're trying to dial back the amount of therapy we get to hopefully lead to less of the late long-term effects that we've heard about earlier today. So we divided patients into those with localized tumors or those with a special type of metastatic disease. So there are some babies with a pattern of metastatic neuroblastoma called MS neuroblastoma. That tumor metastasizes to the liver and to the skin and doesn't like to go to places like the bone or the bone marrow. So it's a very unique type of metastatic neuroblastoma that often presents in infancy. And we know that kids with localized tumors that don't have aggressive biologic features like MYC-N, or kids with this special MS pattern of disease have quite good outcomes, and we're trying to limit the amount of therapy we give. Arm A of the study, at the top of the slide, are patients with localized tumors that are less than a year of age, that don't have any metastatic spread. We're actually observing some of these kids without even doing a biopsy and only intervening if the tumor grows. L2 tumors are bigger. They tend to be wrapped around things like blood vessels and nerves. We were doing a biopsy on those patients and then just using the biology of the tumor, looking for things like MYC-N, looking for unfavorable features, and only intervening with treatment on those that had those unfavorable features. So if everything looked favorable, we could even watch some of these bigger, uglier tumors in toddlers. And then for the MS patients, we know that there are some patients that do quite well with no therapy, but we think it's those babies that present with symptoms like difficulty breathing or liver dysfunction that have the worst outcomes. And so we use those symptoms to develop a score to determine whether they needed treatment or not. And so these are just We recently closed the study to accrual, so I don't have any of the results yet to present to you. But this is just a slide to show that for the most part, we completed our accrual. The other thing I probably should have oriented people to is the numbering system for COG studies. So obviously NBL stands for neuroblastoma. All COG studies start with A. The first two numbers are the year that the study was approved by the Children's Oncology Group. So this study was approved in 2012. It was a phase 3 study, and it was the second phase 3 study approved that year for neuroblastoma. So that's the code. 12 for the year, 3 for the phase, and 2 for the number of studies that were approved that year. The big thing I wanted to highlight here is that we enrolled all of our patients with the exception of this group B. Again, those are the babies that are less than 18 months of age with big, localized but very ugly tumors. And we only enrolled about a third of the patients. And so this highlights that despite our best efforts, and thoughts about how these patients might be treated, sometimes when you're faced with this scenario, the decisions you make are very different. And so I think from talking to other docs and families, many of them were unwilling to just sit and watch an ugly localized tumor. And I think many people wanted to do something about it, like remove it surgically or treat it with chemotherapy and not be on a clinical trial. Okay, so the next steps, now that the studies are closed, we have lots to do. Obviously, we're going to report out the results of the study, but some of the sub-projects that will hopefully emerge out of this are a biology project to look at the banked samples we have from the trial. There are rare patients who die of non-high-risk neuroblastoma and really understanding why that happened. We want to also study the long-term outcomes and late effects of patients treated on this trial and a previous trial. Many of these patients have surgical resections of their tumor, and so we're working with surgeons in the Children's Oncology Group to understand outcomes and side effects related to surgery. And then because we had such a hard time enrolling those L2 patients, sorry, the greater than sign is in the wrong direction, that should be less than, collaborating with colleagues in Europe to understand more about this disease since we had such a hard time enrolling patients. Okay. The next study, again, was conceived in 2015, was a phase 3 study, and was the first study that year, and actually the only study that year, so 1531. This is a study that may be familiar to many people in the audience because this was the study that enrolled from, I believe, 2017 through 2024, or end of 2023. And this was a phase 3 study. So this is trying to define the standard of care for patients with high-risk neuroblastoma. And so the big question of this, there were two big questions of the study. The first is whether MIBG therapy, which Araz sort of touched on, this radioactive treatment that is absorbed into tumors and not by many healthy cells, and we know that that's active in the relapse setting, whether adding MIBG therapy to upfront treatment will improve outcomes. And the second is, based on all of our knowledge, that there's a subset of high-risk neuroblastoma patients with ALK mutations in their tumors that turn on the ALK gene, and that there are drugs that can turn ALK back off. There's also an evaluation of whether ALK inhibitors, which are FDA approved for lung cancer, could be used in neuroblastoma. So this is a very, very busy slide, but I'll try and orient people briefly to it. So in that network of Children's Oncology Group hospitals, if a patient with high-risk neuroblastoma was identified, they were treated with standard chemotherapy, and then most patients were randomized in the middle here. So these middle three brackets were the main questions of the study. Again, because we're studying MIBG therapy, and you may have heard that there are some patients without MIBG avid tumors, that their tumors don't light up on an MIBG scan. If that was seen, patients obviously we wouldn't want to give them a treatment where we didn't think the drug was going to go into their tumor. And so patients with MIBG non-avid tumors were randomly assigned to the standard of care arm. Patients with MIBG, I'll start on the other side, patients with ALK mutated tumors, and that again could be a mutation that turns on the ALK gene or an amplification of the ALK gene, which also serves to turn on the gene, were also non-randomly assigned to get an ALK inhibitor. At the very tail end of the trial, that ALK inhibitor was lorlatinib. We started with an earlier generation of the drug when this study first opened called crizotinib, but for various reasons, mostly due to concerns that the drug was not very active in neuroblastoma, switched to a much more potent ALK inhibitor called lorlatinib. Okay, so if you had those two scenarios, you were non-randomly assigned to an arm, but the bulk of patients don't have an ALK mutation and have an MIBG avid tumor, so they were subject to the main randomized question of the study. So half of the patients would get assigned to the standard of care arm, and then the other patients were assigned to either arm C here, arm B, which was including the MIBG therapy. So if you compare these two arms, everything is the same with the exception of getting MIBG. Now, we know that MIBG therapy, especially in kids that have neuroblastoma in their bone marrow, that the MIBG drug gets into the bone marrow and can suppress the bone marrow. And so people that get an MIBG treatment need a stem cell rescue. It's usually not as aggressive in terms of side effects as a transplant, so you don't tend to get the mouth sores, the need to stay in the hospital for a month, the low immune system, the pain, but we do stem cell rescue. So one of the sort of side questions of the trial was, if we're giving a patient an MIBG treatment, can we get away with a single transplant instead of our current COG standard of tandem? And so that was another question on the study. During the conduct of the study, arm C, where you got a single transplant, was dropped. Again, we don't have the results, but we assume that the dropping of that arm was due to it being less active than the other arms of the study. And we'll soon get those results. And so the main question of MIBG versus the standard of care proceeded on for the rest of the study, and very recently closed to enrollment. So this is the study chairs, Dr. Bagatelle from CHOP and Dr. Du Bois from Dana-Farber in Boston, celebrating the end of the study with a bowl of ice cream. So hopefully they don't get mad at me for showing you that picture, but they were very excited because that was a nearly 10-year adventure to run this trial. The plans is that because, I'll go back just a little bit, because we switched the ALK inhibitor sort of partway through the trial, we actually haven't enrolled enough patients and treated them with lorlatinib to know whether that also improves outcomes. And so the goal is to continue arm E of the study and give standard chemotherapy plus lorlatinib. That's undergoing some amendments in the Children's Oncology Group and getting a sort of freestanding protocol back up and running. But we anticipate that this specific arm for patients with ALK mutations will need to be open for another 2 years before we can get some answers of whether lorlatinib improves outcomes for kids with ALK-mutated neuroblastoma. Okay, so those are the recently closed studies. Let's jump into what's active now. And really this is our main study that just opened in April of 2024. Again, conceived in 2021, opened in 24, but a phase 3 study in the first study of that year, 2131. The hypothesis of this study is that adding dinutuximab to standard upfront chemo will improve outcomes. This is building on several studies that have been done both at St. Jude and in the Children's Oncology Group that suggested that when you add chemotherapy to dinutuximab, it improves response rates against neuroblastoma. The main study I'll highlight, it was run by Dr. Federico here in the first picture at St. Jude, NB 2012, where she used an anti-GD2 antibody similar to dinutuximab from the time of diagnosis and combined it with induction chemotherapies. And again, it's only at a single hospital. That's obviously St. Jude is also highly resourced, and so the outcomes of that preliminary study were suggestive that by adding dinutuximab, they were improving outcomes. Again, we don't know that if that will, I'm from a small town 3 hours south of here called Peoria, and there's the phrase, will it play in Peoria, meaning will it translate to the rest of the world? And so this phase 3 study is essentially mimicking Dr. Federico's St. Jude study to see if adding dinutuximab to induction therapy will improve outcomes. So this is a little bit simpler of a schema than the 1531 I showed. And really, if you're comparing the standard arm to the experimental arm, the only major difference is the inclusion of the antibody, in this case dinutuximab. So patients start treatment, they get, we obviously meet them, enroll them on the study, and then we get a biopsy and confirm they have neuroblastoma. And we start with one cycle of standard chemotherapy in all patients, and that's for several reasons. The main is safety, obviously giving a brand new patient with neuroblastoma who's just diagnosed, oftentimes in a lot of pain, an antibody on top of that may exacerbate their pain was felt to not be justified. And so we start the antibody on the experimental arm starting from cycle 2. So from cycles 2 through 5 of standard induction, the experimental arm patients will get the antibody. We're trying to balance these arms by factors that we know influence outcome, like stage. So we'll lump the metastatic patients and the localized patients and make sure that there are equal numbers of those patients on each arm. We're making sure that there's equal numbers of MIC-N patients on each arm and equal numbers of ALK patients on each arm. We're planning for about 400 patients, and that will take us likely about 3 years to accrue. The other thing that we are doing on this study for the first time is allowing for something that we're calling extended induction. And so this may be familiar to many people in the audience. We know that at the end of those first 5 cycles of chemotherapy, when you do your big set of scans and your bone marrow and your MIBG, we know that for those patients that have persistent disease at the end of induction, that they're, say your Curie score was 12 when you were diagnosed and your Curie score goes down to 8. That's an improvement, but we know that kids with persistent disease like that oftentimes are the highest risk for relapse. And so many people are doing this now as sort of a de facto standard of care, even though we haven't done a study in this population, of giving additional bridging chemotherapy, or in this case, chemoimmunotherapy, to drive that number down, to get people into a deeper remission before they go on to more therapy. And so for the first time, we're going to study that. Again, it's not a randomized question like the one I just showed, but anyone on this study that has a sort of suboptimal response to induction will have the opportunity to get up to 6 additional cycles, and that will include our sort of go-to relapse regimen in the COG of irinotecan, temozolomide, and dinutuximab. Patients that have a good response to this bridging therapy can then go on and stay on study, don't have to come off study like we did in the past, and can get what is determined to be the COG standard of care of tandem transplant, radiation, and then standard dinutuximab. So this will allow us to see whether this approach also leads to improvements in outcome. All right, so I mentioned this is open to accrual. It's actively enrolling patients. I think the last study call I was on, I think there are 16 patients of the 400 planned that have enrolled. Okay, so next steps in the Children's Oncology Group. My colleague in Colorado, Meg Macy, is working hard on a relapse study. We know that many patients now will be exposed to irinotecan, temozolomide, and dinutuximab, both on this 2131 study and as the standard of care in first relapse. So we're looking beyond irinotecan, temozolomide, dinutuximab for other active agents that may help patients that have experienced a relapse. The main concept will include another combination of chemotherapies, topotecan and cyclophosphamide, in this case plus an antibody, and then I have hot off the press, there is a medicine called iberdomide that's going to be added into this cocktail in our next relapse study. So that was just approved by the COG, and didn't have a chance to update my slides because the concept was approved yesterday. Topotecan, cyclophosphamide, dinutuximab, and then the new drug is called iberdomide. Dr. Marcellian talked about a drug called lenalidomide in her previous talk, and it's sort of a relative medicine of lenalidomide. This is less exciting, but there was a major effort in 2024 to change our biology study. In addition to therapeutic studies that the Children's Oncology runs, many families here may know that the COG also runs banking studies where we bank tumor biopsy samples, blood samples, and that has been a tremendous success. That allowed us to bank hundreds of neuroblastoma tumor samples. We created cell lines that have been used in labs in that preclinical phase to test new drugs, and has really enhanced our understanding of what makes neuroblastoma tick and how we might be able to attack it in the future. The COG, I think in part due to the successes of neuroblastoma biology, developed a unified biology process called Project Every Child, or PEC, and developed a freestanding biology protocol that they want all children with cancer to enroll on. And so there were some updates to how we classify high-risk patients, and we're integrating that into this new biology study. But I think what is most exciting about this new biology study is an initiative through the National Cancer Institute called the Molecular Characterization Initiative, or the MCI. And what this is doing is taking selected groups of patients like soft tissue sarcoma, central nervous system tumors, and rare tumors. We just recently added high-risk neuroblastoma patients to this, where if you have that diagnosis, the NCI will perform molecular testing, genetic testing on your tumor at no charge to families. And so this may open up a better understanding of neuroblastoma. It may talk about what is the landscape of the tumor at diagnosis and potential other ways that we might be able to attack it. So having this really rich, hundreds of genes are tested in this sampling approach, I think will also help us drive innovation. So this is available to all newly diagnosed high-risk neuroblastoma patients. And if any families on the call or in the room are within 6 months of diagnosis and have not signed up for this, this is available within the first 6 months of diagnosis. So if this wasn't discussed at your center, it's worth discussing because it's available. Okay, so this is, again, just it sort of pains me to show slides like this, but it's the reality and of sort of the timeline. So we talked about 1531, which is the study evaluating MIBG therapy. We expect that we That study closed in September of 2023, and then we need 3 years of follow-up after the study closes for all patients to see at the 3-year time point, did MIBG therapy or did ALK therapy, for instance, make a difference? And so we anticipate that the primary results for 1531 will be available in the fall of 2026. Dr. Federico, her study, building off the St. Jude experience, opened actually in April of 2024, and so we anticipate that that will take 3 years to accrue. So we anticipate accrual through April or March of 2027, and then 3 years of follow-up. So the results of that study that just opened 3 months ago will not, unfortunately, be available for 6 years. So, and then I'm leading the charge. Again, this is in its sort of early concept stage, so I don't have a lot of information to provide. I'm hoping next year when I come back, I'll have a concept that I can share with this audience, but that we're already in the planning stages for the trial that will follow Dr. Federico's trial. We did just get assigned a number, so ANBL 2431, which was just improved by concept, will actually randomize patients between tandem transplants, which is sort of the standard of care in the COG centers, to chemoimmunotherapy, irinotecan, temozolomide, dinutuximab, as an alternative to transplant. We know these groups of medicines are very, very highly active in the relapse setting, and so we're hoping it can replace transplant. So obviously it takes a village. This is a photo from the COG neuroblastoma committee the last time we were all together in Chicago. This work is a very large group effort, an international group effort, and many of the people that I've listed here were together, which was very nice to get together and share a meal and talk about ideas. And so it's a very dedicated group of docs. I'm inspired every time I get to work with them and collaborate with them, and we're doing our best to try and improve outcomes for this terrible disease. So thanks for your attention. I'm happy to take any questions.
Thank you, Doctor. Anyone have any questions? Nope. What? Go ahead. Go ahead. You can do.
So Dr. Marcellin in her talked about parent advocates being involved in planning of the NANT studies and so on. So my question is, are parent advocates or family advocates involved in planning of the COG trials that you presented?
Yeah, it's a great question. Yes, we have. In fact, I'm wondering if she might even be in this picture, but we do have parent advocates that are involved in the Children's Oncology Group and are providing input into what our studies should be, or when we propose studies, getting a parent advocates committee. And a parent advocate actually sits on the executive committee of the neuroblastoma disease specialty in the Children's Oncology Group. So parents actually have a very strong voice in the COG for what studies we're doing.
Thank you.
Yeah.
Hi, thank you. In regards to hospitals being involved in COG, what type of requirements are needed for them to be involved in COG? Because in talking to certain parents across the country, we're seeing different standards of treatment and willingness to switch protocol and treatments in regards to like tailoring the treatments to the patient's disease response.
Yeah, I think the first part of your question is that there are some basic requirements of how many general patients with oncology that you see at your center. So some very small hospitals that may only take care of 5 or 10 patients with cancer a year may not be COG sites. I'll show you, if I go back to if I can get there quickly, the map, you'll see that it's sort of tightly linked to population, right? That the Central Plains, because they don't have a lot of children's hospitals, don't have a lot of COG sites. So that's really it, is mainly, do you have access to radiology? Do you have access to radiation therapy? Do you have access to a number of patients? And then, the amount of paperwork that goes into filing on these trials is not insignificant. And so you also need a staff of people that can, fill out forms to say, okay, Johnny completed cycle 2 of treatment. Did they get all the doses of medicine that you intended? Did you make any adjustments to that treatment? And how are they doing? And so those are the pieces that go into becoming a COG site.
And then a second question in regards to the new study that you have coming out, or taking kids in now with the chemo and immunotherapy in the front line of the chemo. If those children are responding so well to the chemo and immuno, will there ever be an option for those children to continue on with just that to avoid the toxicities of stem cell transplant?
Yeah. So again, I wish that we could move faster in this regard. The study 2131 that I highlighted here, where kids will get chemoimmunotherapy up front, that we will, they will get, the patients that respond well are still getting tandem transplant on that study. Certainly families have the right to come off that study if they're not interested in tandem transplant and could get continuing chemoimmunotherapy. But we're trying to piggyback on with the study I didn't show any slides about, 2431, of answering that question exactly. So we will very quickly follow that study up with a study of whether chemoimmunotherapy can substitute for tandem transplant. And again, the timeline of when we'll get that answer in the Children's Oncology group at least will probably be in the mid-2030s. But we are working as fast as we can within the context of this giant network of hospitals to try and answer that question.
Okay, thank you.
Yeah.
One more question?
Yep. So on the study that just got approved, the 2431.
Yeah.
So what's informing that one? Is that like a hypothesis, or what studies are informing that?
Yeah, I mean, I think it is not, unlike this study, which is highlighted here, which was based on a clinical trial run at St. Jude with pilot data, we actually don't have as much information about chemoimmunotherapy's ability to substitute for tandem transplant. But it is building off the parent advocacy community of saying, we've been through tandem transplant, we know that the toxicities it brings, and you have this group of medicines that works really well for kids that have experienced a relapse. Can we bring this cassette of treatment up front? And can that substitute for something that we know has a lot of side effects? Especially because there are centers that you may know that aren't doing transplant at all. And so it's sort of building a little bit off of the Memorial Sloan Kettering experience, building off of the COG experience of a highly active relapse combination of medicines. And because it's such an important question, we didn't want to run a trial of, just a single arm trial and say, oh, does this work? We think in collaboration with parent advocates that this is the time to ask that question.
Got it. And would everything else stay, like, so if 2131 is successful, you would still keep the dinutuximab up front, and then you'd go to the chemoimmuno of the TMZ, RN, dinutuximab. So
we won't have the answer. We want to ask this question about transplant versus chemoimmunotherapy as soon as feasibly possible. So we are actually, as soon as this study closes, we're going to open the transplant versus chemoimmunotherapy study. So we won't have the answer to this study of whether adding immunotherapy in the first 5 cycles improves outcome. Okay. We'll get those answers about induction and then transplant sort of back to back. And then I think the future phase would be, okay, can we add that all together? And that might be the era where we're really starting to peel back on treatment. That if adding GD2 antibody in induction improves outcome, substituting tandem transplant with chemoimmunotherapy improves outcomes, can we merge all those together and develop a more immunotherapy-based, less chemotherapy-based treatment regimen?
And post-consolidation phase, it stays the same for both?
Stays the same in both trials.
Great. Thank you.
Mm-hmm.
One more question here.
One more question.
Yeah.
I'm not sure how to ask this question. Would they collect any samples from the parents of the children in this testing era to see if there's any correlation in like the genetic testing?
No, but the new era that I talked about called the Molecular Characterization Initiative, we are also collecting genetic information about the tumor, but also collecting normal blood samples and doing genetic testing on healthy cells in the body. And sometimes, very rarely, we'll find a genetic reason in all of the cells in the body that tells us, why did this cancer develop? And if we find that, then oftentimes we're doing parental testing to see if this was some gene that was inherited. I think the most common example that you hear about in the news is like the breast cancer gene. We don't really have a family neuroblastoma gene, a gene that predicts whether other kids or family members or cousins will get neuroblastoma. But part of this new initiative is to try and figure that out. Are there genes that predict why they got neuroblastoma, and are other family members at risk?
Okay, because we are freshly new to this. My baby got diagnosed this April, and they got genetic testing from me. They got my saliva to see if it was in comparison to the baby's or any of course, we're not going to get any response or any feedback of it because they're going to do what they have to do with it.
Yeah.
But I just immediately said, I wish I could remember the name of the organization or the trial that I just signed up for, because I was just like, if anybody can learn from it, just tell me where to sign. And
yeah. And I think that's very similar to what most parents do. So again, this is sort of what's being done at the national level, and many hospitals are tapped into this. But your hospital may have additional research studies that they're doing. And my hospital in Denver is doing a similar test that you mentioned. So it's not done at the national level, but we're trying to figure out why do babies get neuroblastoma. The good news is that we usually don't find a link, meaning we don't find a gene that causes it. That means for your family that your baby's cousins, siblings aren't at risk of developing this tumor. But we're constantly trying to learn about what are the genes that are involved in people getting neuroblastoma, and can we predict it better?
Okay.
Does that make sense?
Yes.
Okay.
Thank you, Dr. Pinto.
Thanks, everyone.